Okay, sir. Our case patient, 44 years old, male, came to hospital with the right upper quadrant abdominal pain, nausea, vomiting, dyspepsia, jaundice, fever. By physical examination, blood temperature 38 centigrade, tachycardia, jaundice. Biochemical test, increase bilirubin, increase white blood cell, increase SGBT, make ultrasound and MRI and MRCP. This image contains MRI, MRCP, multi-sequence and section. The sequence T1, T2, T1 outpace, T1 contrast, three phases, arterial venous delay. نعم سر. نعم.
بس الهيستوري تشرح كيف على الكيس.
لا سر اعطيت السيكونس في البرزنتيشن مالته.
هو السيكونس هيك.
اوكي سر هو بالاصل كيس patient 44 years old came hospital right up with our right abdominal quadrant, abdominal pain, have dyspepsia, jaundice, fever.
زين دكتور العفو دكتور عزام عيني هي صورة هسه حركة لأن واقفة يمي.
لا اوكي هسه حركة جايك سيكونس تي في دكتورة.
ماشي.
يعني هذا تي 2
ماما لازم وياه صنع إذا فاح صباحها أو صباحها لو ما فاح نفس بس انتظري بس هل أبحث وأقول لك.
هذا تي 2 اوكي هذا الاوتبيس.
بس هذه كملت دكتور كملها للأخير هي هاي سيكونس من البداية اي
اوكي
ماشي.
هذا سيكونس تي في دكتورة.
احنا رجعنا على التي 2 نحكي على الكيس. نعم أستاذ. MRI, multiple sequence of MRI show evidence of dilated intrahepatic biliary tree increase يعني dilated with the circular in appearance with the evidence of يعني low density seems to be يعني stones in intrahepatic biliary tree. يعني الهيستوري مالت البيشنت جوندز وديرينج ليفر فانكشن. يعني هي بيكتشر مالت increase بالانترا هيباتيك biliary increase in intrahepatic dilatation ويعني نخلي الكارولي أستاذ أول واحد، then stones بدي أشر عليهن.
نعم. انت بريش هذا كارولي ديزيز. وداد هذا ترى وداد انفصل الصوت عندنا وداد.
ألو ما أدري الصوت. نعم أستاذ.
انقطع الصوت شيء هسه رجع. هذا كارولي ديزيز بريش.
هاي برأيي كارولي ديزيز أستاذ، لأن يعني بالأمار سي بي شفت بس الانتراهيباتيك، الإكستراهيباتيك كانت نورمال.
نعم.
تسمعني أستاذ؟ صوتي
نعم
واضح؟
اسمعك واضح.
نعم أستاذ. الإكستراهيباتيك نورمال والانتراهيباتيك دايليتد، و يعني ويا الهيستوري مالت البيشنت الجوندز والليفر فانكشن افكتد حسب ما سمعته. سبلين شوية لا
في سبلين.
لا نورمال أستاذ، شيء لا علاج. وما مرات بيصير عندهم يعني افكتد على يعني الليفر الديرينج والليفر فانكشن، بعدين ممكن يؤدي الى بورتال هايبرتنشن.
شكرا وداد، شكرا جزيلا.
نعم استاذ.
مرتضى عبد الرزاق موجود؟
نعم أستاذ، صباح الخير.
صباح الخير. مرتضى.
والله هو أستاذ يعني مثل ما قالت دكتورة، هو أكو يعني دايليتد انتراهيباتيك بلياريتري، وأكو بيها يعني مالتيبل فيلنج ديفكت. الانتراهيباتيك دايليتيشن يعني هايبو بالتي 1 وهايبر بالتي 2، ويعني الفيلنج ديفكت ماستلي هو ستون، فهو يمشي ويا الكارولي ديزيز.
تمام.
نعم.
عندك
يصح ولا يستاهل؟
هنا اكو في السيكونس مبارك بنسوي هنا لو كل شيء مسوي بالسيكونس مع العمران.
بالام ار اي
نعم.
اكو ساين هاي مال سنترال دوت ساين، يعني هاي بالسي تي.
لا هنا
اللي هي
كل شيء كامل ماكو يعني ماكو عندك في النقص.
العفو الصوت شوية.
عندك نقص بالام ار اي لو كل شيء كامل.
هو التي 1 والتي 2 موجودات، يعني إذا ام ار سي بي نشوف يعني نشوف السي بي دي أكثر يعني.
هي ام ار سي بي موجودة بس مو كل شيء.
أي هو بس هاي أكثر شيء، يعني نشوف خاف مثلا يعني السي بي دي ستون أو شيء، يعني الاسوشيتد مثلا الانفكشن يعني كولنجايتس، واذا مثلا ماس ليجن اللي هي كولنجيو كارسينوما.
ماشي شكرا مرتضى. يلا عزام احكي لنا عن
لا.
Okay, sir. This patient, 44 years old, male, that contain, in this case, multiple diffusion on the multifocal segmental circular dilatation. نعم.
عزام صوتك بعيد.
نعم
صوتك بعيد اقول لك.
هسه okay, sir?
اي تقريبا.
Okay. نعم sir. In this case, diffuse multifocal segmental circular dilatation of intrahepatic bile duct. Some show in the portal face show central dot sign. This are the multiple large and small stones associated with a mild dilatation of the CPD about 9 mm. Both kidneys show tiny and small parenchymal cysts. Normal other organs and no ascites or pleural effusion. This is a typical picture of Caroli's disease with the association and complication. أروح التوك ستوب. Okay. Our presentation, Caroli's disease and syndrome. In 1958, Jacques Caroli first described a rare congenital condition, autosomal recessive disorders, in which there was a non-obstructive saccular dilatation of segmental intrahepatic bile ducts. There are two types. Caroli's disease simple type is limited to dilatation of large intrahepatic bile ducts. Caroli's syndrome, very portal type, describes a combination of large and small intrahepatic bile ducts, dilatation, and congenital hepatic fibrosis. The classification of choreographic cysts, a Todornic classification. According to Todornic classification, the Caroli disease is type 5. Type, this table show type, shape, and description. Type 1, the choreographic cyst, cylindric or fusiform segmental dilatation. Type 2, choreographic diverticulum supraduodenal segment. Type 3, choreographic intraduodenal diverticulus. Type 4A, multiple cysts at intra and extrahepatic ducts. Type 4B, multiple cysts at extrahepatic ducts only. Type 5, multiple cysts at intrahepatic ducts only. Or Caroli disease, segmental or diffuse. This image is made by MRCP and ERCP. This MRCP type 1 dissect fusiform dilatation of extrahepatic bile duct, and this supraduodenal diverticulus type 2 and intraduodenal diverticulus type 3, and this type 4 extrahepatic and intrahepatic type 4A. Clinical presentation and pathology. The presentation is in childhood or young, female more than male. Caroli's disease is present with right upper quadrant pain, recurrent cholelithiasis, and cholangitis, with the fever and jaundice. Caroli's syndrome is present with previous symptoms along with signs of portal hypertension, include hematemesis and melena secondary to bleeding varices. The pathology. Caroli's disease and syndrome belong to the spectrum of fibropolycystic liver disease, which result from in vitro malformation of ductal plate. There is a high association with fibrocystic anomalies of kidneys, which share the same genetic defect, PKHD1 gene chromosome region 6p21. Radiographic appearance. The disease may be diffuse, lobar, or segmental. Dilatation is most frequently secular rather than fusiform feature that might help in differential diagnosis. Ultrasonography is often the first imaging idea for suggesting diagnosis, follow-up, and intervention. CT and MRI to detect developing cholangiocarcinoma about 10% risk. ERCP and MRCP. There is advantage and disadvantage of MRCP over ERCP. The advantage, MRCP has ability to see extraluminal, can visualize excluded obstructed ducts, is non-invasive. The disadvantage does not allow for concurrent intrahepatic bile therapeutic intervention, does not actively distend the biliary duct system with contrast. MRCP has low spatial resolution than ERCP. By ultrasound, that show in this image the ultrasound and color Doppler. Dilated intrahepatic, focal, segmental, diffuse, intraductal bridge, echogenic septum traversing the dilated bile duct lumen and a small portal venous branch, partially or completely surrounded by dilated bile duct. Central sign. Intraductal polypi. By CT, multiple on this image that show multiple hypodense surrounded areas which are inseparable from the dilated intrahepatic bile ducts. The central dot sign, enhancing dots within the dilated intrahepatic bile ducts, representing portal radicals. MRI and hypotenuse dilated of intrahepatic bile duct, but in the T2, hyperintense dilated of intrahepatic bile duct. T1 contrast with the godynemia, enhancement of central portal radicals within the dilated intrahepatic bile duct. This is the central dot sign, as this image. MRCP and the ARCP demonstrates continuity with the biliary tree, show ductal anatomy. On the left image, ARCP Caroli's disease with the severe intrahepatic duct dilatation, non-obstruction, mild dilatation of choledochal duct due to pharyngitis. On the right side image, MRCP secular, not fusiform, intrahepatic bile duct dilatation with the normal choledochal system, choledochal duct, and Caroli's disease. Now the complication: intraductal sludge or stone formation about 90%. On this image, on the left side, T2 MRI, and right side MRCP show secular dilatation of intrahepatic bile duct with the stone. Recurrent cholangitis may lead to bacteremia and sepsis. I show in the middle on the left side ultrasound image that show increased wall thickness of bile duct with increased echogenicity or came irregular contour. Cholangiocarcinoma about 7%. Left image, this ARCP, light blue arrow, infiltrated cholangiocarcinoma with the structure and patient have Caroli's disease. Right side CT axial, the yellow arrow, intraductal cholangiocarcinoma, enhancing luminal mass with a delayed washout. Other complication, hepatic abscess, ascites, and varices. As seen in this image of ultrasound, show dilated intrahepatic bile duct with the hepatic abscess. The associations: medullary sponge kidney about 80%. Like this image, CT axial section, we see blue arrow, mild bile duct dilatation, and in the red arrow, medullary sponge kidney with the stone formation. And yellow arrow, this round hyper-attenuated mass in a right liver loop, this case neoplasm. The patient Caroli disease have increased development of cholangiocarcinoma. Polycystic kidney, autosomal dominant polycystic kidney, and autosomal recessive polycystic kidney, about 80%. This is the CT coronal section and the MRI G2 that show mild secular dilatation of the intrahepatic bile duct and autosomal recessive polycystic kidney. Congenital hepatic fibrosis is transformed to Caroli's disease. Caroli's disease or Caroli's syndrome. Caroli's disease and congenital hepatic fibrosis due to ductal plate malformation affecting both small and large intrahepatic bile duct results in cystic and fibrotic changes in liver and or kidney. This congenital hepatic fibrosis, according to this image, the radiological finding, dysmorphic liver, left loop hypertrophy, right loop atrophy, dilated splenic and portal veins, a large abnormal branching of hepatic arteries, atrophied kidney. This another image show pseudo lesion or segment 2 in the left loop with hepatic fibrosis and the mild dilatation of intrahepatic bile duct of Caroli's disease. Differential diagnosis of bile duct dilatation according to bile duct dilatation, non-obstruction, Caroli disease, choledochal cyst, recurrent biogenic cholangitis, primary sclerosing cholangitis. obstruction, the stone's structure. Structure, there are neoplasm, post-inflammatory, and inflammatory. Neoplasms, cholangiocarcinoma, gallbladder adenocarcinoma, pancreatic adenocarcinoma, metastasis, post-inflammatory pancreatitis, post-radiation or chemotherapy. Inflammatory AIDS cholangiopathy, biliary parasitis, primary sclerosing cholangitis. Differential diagnosis of Caroli's disease. Polycystic liver disease, non-associated biliary duct dilatation, rarely communicated with biliary ducts, peribiliary cyst, periductal cyst, biliary hamartoma, may be cystic, primary sclerosing cholangitis, dilatation typically more fusiform and isolated, associated inflammatory bowel disease, 70% of Caucasian patients. Recurrent biogenic cholangitis was present with sepsis and biliary dilatation. Secular dilatation covers Caroli's disease. Obstructive biliary dilatation. The treatment depends on clinical features and location of biliary abnormality. Antibiotics are used to treat the inflammation of bile duct and also deoxyfolic acid for hepatolithiasis and ursodiol for polylithiasis. Localized to loop or segment hepatic lobectomy or segmentectomy. Diffuse disease. Treatment options include conservative or endoscopic therapy, internal biliary bypass procedures, and liver transplantation. A description of Caroli disease and syndrome for this reference. Thank you.